we're jumping right into a totally fascinating and, let's be real, notoriously complex systemic condition, psoriatic arthritis. You already know that with rheumatology, we're basically connecting a massive puzzle across the entire body. So today, we're going to break down exactly how this disease operates, bridging that gap from microscopic immunology all the way to what you actually see in the clinic.
To really grasp the impact here, we've got to look at the scale. Now, in the general population, it's pretty rare, hovering around a 0.2% prevalence. But look at that 40% figure. That is a massive chunk of patients with existing psoriasis who will actually go on to develop psoriatic arthritis. And get this, it's not just a disease of old age. It typically hits people right in the prime of their lives, usually between 25 and 40.
Which brings us to our first major clinical pearl about the timeline. You might assume the skin plaques and the joint pain show up together, right? And hey, occasionally they do develop synchronously, but way more often the musculoskeletal disease and the skin issues are separated by literally years. Usually the skin stuff shows up first, which makes catching that impending arthritis super tricky. It really demands some serious vigilance on our part.
All right, so here's our roadmap for today's explainer. 1. What is psoriatic arthritis? 2. Genetics and pathophysiology. 3. Recognizing clinical joint patterns. 4. Skin and nail manifestations. And 5. Diagnosis and investigations.
Let's jump into part 1. What is psoriatic arthritis? So right off the bat, psoriatic arthritis isn't just an isolated joint issue. It's actually part of a family of diseases called the spondyloarthropathies, specifically branching under peripheral spondyloarthritis. But heads up, peripheral definitely does not mean localized. When we map out this inflammation on the body, it's everywhere. We're talking uveitis in the eyes, inflammatory bowel disease in the gut, psoriasis on the skin, and enthesitis down at the heel. It is a true, full-body inflammatory state.
Moving on to Section 2, Genetics and Pathophysiology.
This disease definitely doesn't strike at random. Family studies tell us the heritability of psoriatic arthritis actually exceeds 80%. I mean, that is a massive genetic loaded gun. The heavy hitters here are variants in the HLA-B and HLA-C genes, along with some overlapping susceptibility loci it shares with psoriasis itself. But you know, the genetics are really just the setup. We think an environmental trigger, like an infection or even local trauma, is what finally pulls the trigger, kicking off a whole cascade of immune activation in these susceptible folks.
Okay, so what actually happens when that trigger gets pulled? Let's trace the cascade. First, dendritic cells go into overdrive producing interleukin-23, or IL-23. This acts as a major signal that flips the switch on Th17 cells. Those Th17 cells then start pumping out a highly pro-inflammatory cytokine, IL-17. It's this IL-17, teamed up with other mediators like TNF-alpha, that acts directly on macrophages, stromal cells, and osteoclast precursors. The end result? We're looking at vasodilation, pain, cartilage breakdown, and actual physical bone erosions at the joint.
All right, on to Section 3, Recognizing Clinical Joint Patterns.
Now, one of the absolute trickiest parts of psoriatic arthritis is how much it varies. The joints are usually painful and stiff, sure, but they aren't always overtly swollen right out of the gate. We see these really stark contrast in presentations. Most commonly, it's an asymmetrical polyarthritis that shows up in this distinct ray pattern affecting the single digit. On the flip side, it can show up as a symmetrical polyarthritis with transverse involvement, especially hitting those distal joints. And remember, these patterns aren't mutually exclusive, they can totally change up on you.
Because it varies so much, we've got to hunt for the hallmark signs. And one of the absolute textbook features here is dactylitis. Clinically, it gets called a sausage digit, but we need to understand exactly why it looks like that. It happens when you get this potent triad, synovitis in the joint, plus tenosynovitis in the tendon sheath, plus enthesitis right where the tendon inserts into the bone. All that adjacent tissue inflammation just swells the whole digit uniformly.
So in the real world, what does that actually look like? Well, you get a diffusely swollen index finger that totally loses its normal joint contours. Or you might see that exact same uniform swelling pop up abruptly in a toe. This dactylitis is incredibly characteristic of the spondyloarthropathies, and it's an absolutely critical clue when they're evaluating a patient's pain.
Now think back to that symmetrical pattern we just talked about. This one can be a massive diagnostic trap because it looks so incredibly similar to rheumatoid arthritis, hitting small and large joints in both the upper and lower limbs. It makes up about 25% of cases and is predominantly seen in women.
So how on earth could we tell them apart clinically? The major distinguishing feature is the total absence of rheumatoid nodules and those other extra-articular features you'd expect with RA. Plus, the arthritis in PSA is usually a bit less extensive and more benign compared to severe RA.
Though I definitely use the word benign pretty cautiously here, because in about 5% of cases, the disease is just devastatingly severe. We're talking about arthritis mutilans. It's a rare, deforming, highly erosive arthritis targeting the fingers and toes. The cartilage and bone destruction is so prominent, resulting in such crazy instability that the surrounding skin literally folds in on itself. This is what we call telescoping fingers, where you can actually pull a finger back out to its original length. It's a really heartbreaking end-stage deformity.
Let's shift gears to Section 4, Skin and Nail Manifestations.
Since the joint symptoms can be all over the map, the skin and nails are incredibly informative. You might spot that disseminated plaque psoriasis right away with its classic silver-white scaling, but hey, even if their skin is totally clear, look closely at their nails. An amazing 85% of patients with psoriatic arthritis have nail changes. We're looking for deep nail pitting, which comes from deficient keratinization, and onycholysis. That's when the distal part of the nail plate actually separates from the bed.
And this is where we really connect the dots clinically. Psoriatic nail disease isn't just hanging out doing its own thing, it is uniquely and directly tied to arthritis, specifically in the distal interphalangeal or DIP joints of the fingers. If you've got a patient sitting there with swollen, inflamed DIP joints right next to nails showing severe pitting or dystrophy, your clinical suspicion for psoriatic arthritis needs to skyrocket immediately.
Finally, Section 5, Diagnosis and Investigations.
So we've pieced together the genetics, the joint patterns, and the skin findings. But here is the most crucial thing to remember. There is no single magical blood test for this. The diagnosis is made heavily on clinical grounds. Actually, autoantibodies like rheumatoid factor are generally negative, and acute phase reactants like CRP are only elevated in a fraction of patients. Because of this, we lean super hard on the physical exam and targeted imaging. X-rays might show those classic erosive changes, but more and more we're using MRI and ultrasound with power Doppler to catch early active synovial inflammation and enthesitis long before any irreversible bone damage sets in.
To standardize all of this, we rely on the Casper criteria. Basically, a patient needs inflammatory articular disease plus 3 or more points from this list. Notice how heavily it weights the physical exam. Current psoriasis gets you 2 points, but you also rack up points for a history of psoriasis, psoriatic nail dystrophy, a negative rheumatoid factor, current or past dactylis, and any evidence of juxta-articular new bone formation on an X-ray. Grab 3 points across these categories, and you firmly nailed down the diagnosis.
Before we wrap this up, I want to leave you with one last super vital clinical pearl. Keep in mind that this disease is a total moving target. The joint patterns we talked about, they don't just vary between different patients. They actually change over time within the exact same patient. Oligoarthritis, where it just hits a few joints, is way more common right at the onset of the disease. But if it's left unchecked, it frequently evolves and spreads into a much broader polyarthritis later on.
Which brings us to a rather provocative final thought. If we know these joint patterns evolve and get worse over time, how will the new generation of highly targeted biologic therapies, the ones specifically shutting down that IL-23 and IL-17 pathway we looked at earlier, how will they ultimately change the long-term clinical picture? Could we prevent those severe end-stage deformities altogether? It's a seriously exciting frontier in rheumatology right now. Anyway, thank you so much for joining me for this explainer today. I really hope it brought some clarity to what is honestly a super complex topic. If you found this breakdown helpful, please remember to subscribe to the MedMedicine channel for more highly focused, slide-based medical deep dives. Catch you next time.